Hi there, my name is Saakshi Khattri. I'm a board certified internist, rheumatologist, and dermatologist at the Icahn School of Medicine at Mount Sinai and an IPC counselor. Today, this sort of 10-minute video presentation is about psoriatic arthritis, which, certainly as rheumatologists, we know a lot about, but as dermatologists seeing patients that have psoriasis, it's always something to keep in mind, but does this patient have PSA or not? And diagnosing PSA is a challenge. So hopefully in the next few slides, I can sort of simplify PSA for my viewers. So the things that we'll touch base today is, the disease burden of PSA. You'll appreciate how heterogeneous this disease is because there are 6 different domains of PSA, and patients can really have various permutations, combinations within those 6 different domains. So it's a very heterogeneous disease. How to diagnose. And then I will say that as a rheumatologist, we don't have a clinical biomarker, we don't have a biomarker or a blood test that I can use to diagnose PSA. And in the absence of erosions, joint space narrowing on imaging, or, signal changes on MRI or on positive Doppler on ultrasound, sometimes the diagnosis of PSA can be a hard diagnosis to make. And then we'll sort of through this entire conversation, we'll talk about maybe some clinical tips that my derm colleagues can incorporate when they see a patient with psoriasis and they're suspecting PSA. Okay, it is an inflammatory musculoskeletal disease that is associated with psoriasis. A majority of the times patients that have psoriasis and then they develop PSA, and that can be seen in up to 30% of patients that have psoriasis, depending on published data sources. Generally, it's in the age group of 30 to 50 years with an equal representation in both men and women. And you have peripheral arthritis, which is one domain, which is seen in a majority of cases. You have axial PSA, which is seen in about a third of patients that have psoriatic arthritis. Then you have enthesitis, and we'll talk about Leeds enthesitis index, which is something that I incorporate in my practice, and that's something that is generally a secondary endpoint in clinical trials. There's dactylitis, that's the 4th domain of PSA. Certainly patients have skin involvement. So 85% of the times patients will have psoriasis before they develop psoriatic arthritis. And the last and final domain, which is domain number 6, is nail psoriasis. So again, it's so heterogeneous. It's not like a cookie cutter, patient that you can't. So there's not a cookie cutter approach to PSA, as in that there is not like a prototypical PSA patient, just because you have so many different domains of PSA, and it's very heterogeneous. And then in addition, to add more complexity, patients with PSA can have extra-articular manifestations. They can have inflammatory eye disease, they can have inflammatory bowel disease, and certainly cardiovascular disease as well. So this slide sort of just talks about the extra-articular manifestations that can be seen. Right. So this is a picture from my room textbook. And this picture of the same patient, both hands, just shows how heterogeneous this disease can be. You have dactylitis, which we all know as sausage digits. Then you have mutilating arthritis, which is that arthritis mutilans. Thankfully, we don't really get to see that often now, unless, of course, the patient had that pre-advent of systemic therapies or biologic therapies. And then you have ankylosing, ankylosis, which is that when there is involvement of the joint, and then, they have like a fixed deformity. And in that image in front of you, you could see that there is a fixed flexion, or what appears to be a fixed flexion deformity. And then you have a normal joint for comparison point, and then you have a DIP synovitis. So again, very heterogeneous. So if you're looking for just one sign, you will miss out on PSA. Right. I mentioned the 6 major domains, and this slide sort of highlights the breakdown of all the domains. You have images of nail psoriasis, you have pitting, you have onycholysis. These are some clinical images of patients that I see in my practice. Again, that arrow on the hand, picture shows you DIP synovitis. And it's the same patient's foot. You could see mutilating arthritis. He had PSA diagnosis before there were even biologics approved for PSA. So again, sort of just driving home the point that this is a pretty heterogeneous, presentation, heterogeneous disease. A different patient, you could see the ankylosis or the ankylosis that has taken place, and you can kind of appreciate that on the lateral view of the hand. But then, when you're at the top view of both hands, you can see some joint swelling as well. Like, and then you can see some normal fingers. So again, very heterogeneous. This is a Achilles enthesitis, and it can be asymmetrical. It doesn't have to be symmetrical. And you can see the right Achilles is swollen compared to the left side. This is an example of dactylitis, which is that inflamed digit. So historically, there was like a Moll and Wright classification of PSA. You could have DIP involvement, you could have mutilating arthritis, symmetrical polyarthritis, which involves small joints of the hand, notably MCPs, PIPs, which clinically is indistinguishable for rheumatoid arthritis. Then spondylitis, which is our axial PSA. And last is asymmetrical oligoarticular arthritis, where you can have involvement of up to 5 sort of joints at different parts of the body. Okay. The big question is, is it PSA, is it RA? So take home message from the slide is that enthesitis dactylitis is really a PSA thing. As opposed to RA, it's not typical in RA. So if you have a patient that has psoriasis, that has enthesitis dactylitis, he or she has PSA. We also know that a delay in diagnosis is associated with worse outcome. Even a 6-month delay from the onset of symptoms has, worse outcome for patients with more erosions and, joint space narrowing that can be seen. So in terms of, what are the risk factors, or what do our patients have that sort of increases their risk of PSA? There's some data that says that if they have, a more severe skin involvement, that increases the risk of PSA. More than 3 different body sites affected by psoriasis increases their risk of PSA by 2.24-fold. And then location. I live in Manhattan, where location is everything. So location of psoriasis can increase your risk of PSA. So if you have scalp and nails, like really the 2 main things that we should look for, scalp 4 times higher chances of having PSA, nails 3 times higher. So certainly if you have patients that has scalp, nails, always think of PSA somewhere, or at least ask them about PSA. Screening tools, there are validated screening tools. This slide summarizes all of them, but really the easiest to administer is the best. It's validated, it's free to use, 5 questions. I give it to all my psoriasis patients. My MA hands it out to them as they're waiting to be seen. They fill the questionnaire up. A score of 3 or higher makes me start thinking of PSA. Certainly as a dermatologist, you're welcome to refer out those patients to rheumatology. I, being a rheumatologist, I do a formal joint exam. And this is what the best questionnaire looks like. They ask questions like, have you ever had a swollen joint or joints? Has a doctor ever told you that you have arthritis? Do your fingernails or toenails have pits? So indicative of psoriatic nail disease, pain in the heel, indicative of Achilles tendonitis. And then, dactylitis is the last question, where a finger or a toe was completely swollen and painful for no apparent reason. The CASPAR criteria is a criteria that's used to diagnose PSA, but this is not a it's not a criteria that can be easily incorporated in clinical practice. So this is more of like, hey, we have a clinical trial in PSA, we use the CASPAR criteria. This is to make sure that it's a homogeneous population in clinical trials with PSA. So not practical in an everyday setting to use in clinic. So what do I ask, or what do I look for? So the first and most crucial thing is to help sort of figure out, is this inflammatory arthritis or non-inflammatory arthritis? And that's kind of key to a proper diagnosis. So the features of inflammatory arthritis tend to be things like, prolonged stiffness upon immobility, or morning stiffness, and 30-minute is kind of like that cutoff that I'm looking for, because sometimes patients who have osteoarthritis or just wear and tear arthritis do report some morning stiffness, but that really tends to be in single digits, 5 minutes, maybe 10. So if I have a patient that says, they kind of stiff for 30 minutes, it starts making me think of PSA. I examine joints. I don't expect my derm colleagues to examine joints, but if you shake their hand and they kind of complain of pain, or you sense that their hand feels warm to touch, or their joints feel swollen, that's kind of PSA for you, or that's like a surrogate way of testing for swollen joints and tender joints. Enthesitis. I do look for enthesitis, and we'll talk about the Leeds enthesitis index. I do look for dactylitis. And then I also ask patients about, back pain, back stiffness. And, like I said, I do a formal joint exam. I don't expect my derm colleagues to do that. I do send out HLA-B27. inflammatory markers because about 50% of the time, they could have an elevated ESR-CRP. I do also check for RF-CCP because you want those to be negative. You've seen this picture below, Achilles tendonitis. So enthesitis is something that we in the derm space can easily look for. And enthesitis is inflammation of where the tendon or the ligament inserts into the bone. It is more common in PSA than other forms of arthritis. So that's why it's a helpful clinical exam finding to, to do and look for in a patient that has psoriasis. And, enthesitis can precede the development of like obvious PSA in patients that have PSA. So if we as dermatologists look for enthesitis and we have a psoriasis patient that has enthesitis, we should think that he or she has PSA. So looking for redness, swelling, tenderness on manual palpation in and I do the Leeds enthesitis index. So the lateral epicondyle, the medial femoral condyle, and the Achilles tendon insertion. Super easy to do. I've timed it in my clinic, putting my derm hat on, and it takes less than 30 seconds. Okay. The other things that clue me in that a patient has PSA, if they have inflammatory eye disease, notably uveitis, that was found to be a predictor of PSA in patients that have psoriasis. If they report some extra musculoskeletal manifestation, ocular, as I mentioned, uveitis, or GI, like, IBD or subclinical IBD, that sort of makes me think more that they have PSA. The last few slides, we'll talk a little bit briefly about axial PSA because, axial PSA is seen in a third of our PSA patients. They report back pain, stiffness in their back. Sometimes they can have pain that wakes them up in the middle of the night, and you will see some asymmetrical sacroiliitis on an X-ray. And, on an MRI, there'll be some bone marrow and soft tissue edema. In the core Evitas registry, which was previously called Corona registry, patients with axial involvement tended to skew a little younger. They had worse clinical outcomes and patient-reported outcomes, compared to those patients that did not have axial involvement, and they had a greater impact on work productivity and quality of life. So I kind of ask about axial disease as well. And, what the other thing was seen is that patients that do have sort of axial PSA and are HLA-V27 positive tend to also have uveitis and IBD. So, I know 10 minutes is probably not enough to really talk about PSA or take a deep dive, but just to, summarize, brief overview, any psoriasis patient is at risk of PSA. For the most part, you have psoriasis first, and then you have PSA. The time to developing PSA could be 7 to 10 years. 6 different domains, very heterogeneous. We must ask questions. PEST questionnaire can be handed 3 points or higher. You can send them to rheumatology. If you're not doing the PEST questionnaire, depending on, what do they have? If they have scalp, if they have nail, increased risk of PSA. Ask for morning stiffness, 30 minutes or higher, or stiffness after prolonged immobilization, should make you start thinking of PSA. And certainly if they have like a swollen joint or a tender joint, that's obvious on, a clinical exam, that's PSA. Enthesitis, super easy to do. Leeds enthesitis index, please look for that, look for enthesitis in those areas in a patient that has psoriasis. If they have enthesitis and psoriasis, they have PSA. And, if you're taking that one extra step, if they talk, if you ask a history and patients say, they've had uveitis before, and they have psoriasis, that's PS, that increases, the odds or the chance of the patient having PSA. I do have an interesting story when it comes to that last point that I made. This was, a few years ago. I had this young male in his mid-30s who came to see me with just some scalp psoriasis and very minimal disease on his skin, not even 1% body surface area. And I'm asking him, and then I asked him, hey, listen, do you have joint pain? He's like, not really, and no morning stiffness. So then I asked him, how about Achilles tendonitis or enthesitis? And he's like, what, I've had on and off Achilles tendon issues. There was really nothing. Maybe there was a minimal tenderness on an exam with maybe a little bit of swelling. And, he did have scalp psoriasis, didn't have nail, less than 1% PSA. And then I asked him, have you ever had inflammatory eye disease, or have you ever seen an ophthalmologist and been told that you have uveitis? The answer to that was yes. So I was like, what, you have PSA, you have scalp, you have skin, you have, enthesitis, and you have extra-articular, inflammatory eye disease, uveitis. I did put him on a systemic agent, a biologic, and he has not once, and he's been on a biologic now for 4 years, not once had a joint issue. So, probably diagnosed his PSA early enough. So with that, I'm going to wrap this up. Thank you so much for listening.